welcome two very esteemed colleagues, Dr. Muna Al-Maslamani, the Medical Director of the Communicable Disease Center, and Dr. Susu Zahir, the Associate Professor of Microbiology at the College of Medicine at Qatar University. So welcome to our speakers today. Before we start today's presentation, I would like to draw your attention to our website, which contains the information of our upcoming events. So for many of you who've registered for today's event, you would have registered through the website, and you can use the website also to claim your CPD certification. So following today's event, the evaluation link will become live, and you will be able to complete the evaluation to claim your certificate. The next CPD event that we have coming up will be in 2 weeks' time, and thereafter we'll continue our CPD events every 2 weeks. Let me just grab the schedule for you. I think
I think Dr. Zakaria has issues with internet. Mr. Shuja?
Yes, it's I think internet issue. It's okay now. Coming up.
Apologies, everyone. Wait with us. Bear with us a minute. It will be fixed.
Okay, I think I'm back. My apologies.
It's okay.
Can you hear me now?
Yes.
Yeah, so so we'd like to draw your attention to the website, where we've now added further events that we'll be hosting over the next few weeks. So we encourage you to sign up to attend the events and to claim your certification afterwards. So the next event will be in 2 weeks' time, and registration is now open. For those of you who are joining us on YouTube, welcome. We'll be monitoring the chat function both in WebEx and on YouTube throughout today. So we're looking forward to your participation. I know that there are some case studies that we hope that you will engage with and contribute your answers to. And Dr. Susu will be moderating the session throughout. Dr. Susu, I'll now hand you over to become the presenter, and you can introduce to today's session.
All right. Thank you very much, Dr. Zakaria. Welcome, everyone, to our CPD tonight that will be on the topic of antimicrobial stewardship. And if you ask why this topic is important, you're probably aware that there is another pandemic in the making called antimicrobial resistance. It has been the issue for the past few years. The World Health Organization and many health authorities across the globe had noticed and observed the surge in number of antimicrobial resistant infections that will lead to treatment failure. And there's actually a global action plan to address this pandemic before it becomes a reality dawns upon us when you are a physician trying to treat your patients, but your antibiotics are not working. So that's what we fear, and we don't want to go back to pre-antibiotic era before the World War II, actually. So when we think of our current antibiotics, as many of them luckily still working against many infections, there are some that are considered last resort antibiotics. And these last resort antibiotics, that we need has to be preserved from the counterattacks from bacteria. We do not want pathogens to develop resistance against our last resource antibiotics. Why this is important? Because the pipeline for discovering new antibiotics is almost dry. Pharmaceutical companies find discovering antibiotics as non-profitable, and they don't invest money in producing novel antibiotics to the market, as it costs fortune of money. And then within 5 years, they may lose these antibiotics and lose the profit. But right now, as I said, there's the Global Action Plan that will address seriously the problem that's facing us. You might heard that among the global threats for human health, antimicrobial resistance, AMR, is one of those threats that we are facing as human. So what do? We just let it grow or face it? We face it, and how we face it? By implementing antimicrobial stewardship program. And antimicrobial stewardship is not just to know when and how to use antibiotics, the proper use of antibiotics. It involves also infection control processes. It involves education and awareness. It involves community involvement in antibiotic use compliance and proper administration. It involves the agricultural and farming industry to limit the use of antibiotics as well in the food chain. It involves research and discovery, so there are many elements to antimicrobial stewardship. As healthcare professionals in our audience today, you are going to hear in depth about the topic of antimicrobial stewardship from our expert, Dr. Muna Al-Maslamani. And it gives me the pleasure to introduce to you Dr. Muna Al-Maslamani, who is the medical director of all COVID cases in Qatar. Dr. Muna has been appointed in this role because of her active involvement in the system for several years. She is the director of the communicable diseases at Hamad General Hospital. She's also the assistant head of infectious diseases division at HMC. Dr. Muna is a senior consultant in transplant infection disease. Yes, and she's board certified in internal medicine, as well as she's infectious disease fellow. She has a membership in the American College of Physicians and also a member of the Infectious Diseases Society of America. She's the vice chair of Quality and Patient Safety Medicine, and she's been very accomplished in terms of achieving quality and improvement in the system. She so far produced more than 55 projects related to quality improvement and patient safety, which is very significant, mashallah, Dr. Muna. In addition, she's also an academic. She holds academic title as Associate Professor of Infectious Diseases in affiliation with Cornell Medicine. And of course, with us, we're very glad to have you with us. Dr. Muna has 67 publications in the last 5 years related to her research, and she's very well funded from QNRF by the NPRP grants, a total of more than $2 million worth of research money that yielded a lot of these publications. Dr. Muna is a frequent speaker in many other activities, not just in relation to infectious diseases. She participates in community awareness. She participates in UNESCO-sponsored Women in Science and many other activities. We are very delighted that you're with us, Dr. Muna. Thank you for sparing your time here. And without further ado, please share your slides. The floor is yours.
Thank you very much for your introduction. I would like to thank Dr. Susu and Dr. Zakaria and Qatar University for their invitation, and good evening for everyone. So did you see my slides, or I need to share again?
Yes, you need to share your slides, please.
Now it's clear?
Yes, thank you.
Okay. So, Bismillah ar-Rahman ar-Rahim, and good evening for everyone. So I will talk today about ASP program experience in Qatar. I don't have any conflict of interest or in relation to this presentation. So the objectives from this today webinar, discuss about antimicrobial resistance, define antimicrobial stewardship program and the objective from that program. We're going to discuss about the CBC core element, hospital, outpatient, nursing home, recommendation for implementations, what's the role of the healthcare workers and the antimicrobial stewardship program. I will touch on a national ASP program as well as corporate and facility, and then we will conclude with a few slides. So if you see, this is like a phases or multi-phases of antimicrobial resistance. And as you know today, AMR is a global crisis and should never have come as a big surprise for us. Since, you know, in 1945, 17 years after like Alexander Fleming announced his monumental discovery of penicillin, which was in 1928, he wrote that the microbes are educated. Imagine that the microbes educated to resist penicillin, and the host of penicillin fast organism is bred out. In such cases, the thoughtless person, so the one who's not caring about antimicrobial or about antibiotic, playing with the penicillin is morally responsible for the death of the man who finally, you know, succumbs to infection with the penicillin. So he thought since that time about resistance organism and hope this evil can be averted. So since that time, he was concerning about misuse and abuse of antimicrobial. So who's responsible for that? Is there anyone who's responsible for AMR? Everyone says no, or everyone they will accept and they will say yes, partially. But for my opinion, everyone, every single person, his partner in antibiotic resistance. So everyone is responsible to, you know, combat antimicrobial resistance. So what is the antimicrobial resistance? So antimicrobial usually included, we are not talking about only antibiotic. Antimicrobial, that means antibiotic, antifungal, antiviral, antiparasitic, and all of the medicine used to treat certain infections in human in animals as well as in agriculture, which is the food, and even in the environment. So what's AMR? AMR occurs when the bacteria, either fungi or even like viruses and bacteria and parasite, change with the time of utilization of antibiotic to be changed over the time and no longer respond to this medication. So making infection for us harder and harder to treat and increasing the risk of spread the disease across the country, then across the world, and then it will happen, it end up with a severe illness and death as a result of antimicrobial resistance. And the other antimicrobial medicine become ineffective and infection become increasing difficulty or sometimes impossible to treat. And this is reality because we are facing this one in our clinical practice, especially in the ICU patients. So this is the timeline and brief history of resistance and antibiotic show timeline of antibiotic resistance compared to the antibiotic development, as mentioned by Dr. Susu, that not anymore the company, they will produce new antibiotics. There is a drive of antimicrobials. And, you know, as you know, the penicillin as a commercial antibiotic was discovered in 1928 by Alexander Fleming. Ever since, there has been discovery and acknowledgement of resistance alongside the discovery of new antibiotics. In fact, germs will always smart, and they will look for ways to fight and to survive and resist new drugs. More and more germs are, sharing their resistance with another germs, and it will make it harder for us to keep up. So imagine that after a few years, there is no new antimicrobials. And if you will see the history of antibiotics and the resistance, it's developed because of over-prescribing and misuse or inappropriate, utilization of antimicrobials. So how antibiotic resistance happen? Usually, AMR happen when germs like bacteria or fungi develop the ability to fight or deviate the drugs which is designed to kill them. But that means the germs are not killed and continue to grow. So it will become more resistance. And AMR doesn't mean that body is becoming resistant. The body, it's not becoming resistant to antibiotics. No, it's the bacteria or microbes that they are resistant to the antimicrobials designed to kill them. So, antibiotic will be kill, the good bacteria, protecting the body from the infection, and will be kill the, the bad bacteria. That's why the resistance, the drug resistance will be developed and will be allowed and grow and will take, over. And, as I said for you before, the germ will be transmitted, the resistance from one bacteria to another bacteria or from one germ to another germ, causing more problem for us. If you will see, this is the state of antimicrobial resistance. And this is the data from CDC USA. If you will see that they are comparing AMR in 2019 with 2013. So AMR was increasing more than 2.8 million in 2019 compared to 2013, and the death is also increasing. And there is, they look to a lot of MDROs like carbapenem resistance enterobacteriaceae, or even extended spectrum beta-lactam enterobacteriaceae, and they categorize the disease based on, a certain assessment. We will discuss it later on. They put like, urgent, concerning, or like serious. AMR or like microbial resistance, it will be impact on a healthcare cost at the end, so they cost them like 20 billion in excess for related to the healthcare cost, and the cost around $35 billion also. And this is what lead to the, this is all due to like increasing MDROs across the system or even in the community. So same for Clostridium difficile. If you imagine that the estimated healthcare cost in 2017 around 1 billion, but even see the death, it's around more than 12,000 patients died in 2017. And same for drug resistance. This is tuberculosis, and TB is caused by Mycobacterium. That bacteria usually attack the lung, and the drug resistance TB developed with the antibiotic used to treat, tuberculosis, either misused or mismanaged. Even sometimes the patients, they will not follow up. They will be escaped from the system. And it's happened with us, people that are frightened from the tuberculosis, and they thought that the country, they will deport them. That's why they are not coming in a follow-up or regularly to follow up with us. And it's really, really impact on the public health. If you will see AMR and COVID-19, so I put the slide because really we are facing an issue with the COVID-19, and there is a reported of antimicrobial resistance during the COVID-19 era. As you know, COVID-19, it's not a bacterial infection, it's a viral disease. It causes or affects the respiratory system and can lead to the severe complication and requiring hospitalization. And up to now, there is no cure for COVID-19. But what will happen in the system? So either in our system or worldwide. So if you will see the clinical guidelines, the COVID-19 management, you will see there is a lot of antimicrobial therapy, antibiotic, which is either you need to utilize it as a treatment empirically for community-acquired pneumonia. So anyone who will enter the hospital as a pneumonia, but we are sure this is COVID-19, pneumonia, they will start empirically on community-acquired pneumonia covering bacterial infection for query suspected bacterial infection as a secondary bacterial infection or co-infection. And they estimated that around, at the end of 2020, around more than 2 million people will have died due to COVID-19, and more than 700,000 people will have died due to drug resistance infection. And around 87.7% in some hospitals, they are writing or prescribing and administer early antibiotic therapy for COVID-19 patients. And this is also, it's happened here in the state of Qatar. So every time I'm doing a serial meeting with the all COVID-19 hospital, despite the antimicrobial, it's in our specific guidelines, but still I'm telling them you need to be cautious about antimicrobial resistance. And once you suspect the patient has secondary bacterial infection, you need to start, otherwise you need to stop, the empirically antimicrobial therapy for community-acquired pneumonia for suspected bacterial infection. So only 7% out of 87.7% COVID-19 patients were found to have bacterial co-infection or secondary infections. So imagine 87, they started them on antibiotic for CAP, and only 7% they have co-infection or secondary infection. So antibiotics do not work in COVID-19 because it's a viral infection, it's not a bacterial infection. And there is a certain study indicated that 30 to 50% of antimicrobial prescribed in the hospital unnecessarily or inappropriate. So there's no doubt that over-prescribing or misusing is contributing on ongoing challenges posed by resistance organisms like Clostridium difficile infection. So, if you will see this slide, this is as I told you, CDC conducted an assessment for AMR. They categorized the threat level of each bacteria as urgent, serious, or concerning. So, threat were assessed according to the 7 factors associated with the resistance infection. They looked at the clinical impact. They looked at the economic impact, they looked at the incidence, to barriers to prevention, availability of active antibiotic transmissible as 10 years of projection of incidence. And if you're going to talk about antibiotic resistance, so as I told you before, antibiotic usually fight the germs, so the bacteria and the fungi, but the germs also very smart. He will start to look back and fight back, the antibiotic, and find new ways to survive. So their defense strategy, we call it, resistance mechanism. So bacteria developed resistance mechanism by using certain instructions, and this instruction is provided by their DNA often. And this resistance gene are found within plasmids, small pieces of the DNA that carry genetics instruction from one germ to another germ. This means that some bacteria can share their DNA and make other germs become resistant. They have like 5 mechanisms for for the germ to have a defensive mechanism for them. So the germ gets rid of antibiotics using that way, and germs also change the antibiotic target so the drug can be no longer fit and he cannot do the job in a proper way. Also, they restricted, access by changing the entryway or limiting the number of entryways, and also germ change or destroy totally, the antibiotic with the enzymes, a protein that break down the drugs. And the fifth strategy for the germs, they developed a new cell process that avoid using, antibiotic targets. So this is the 5 defensive mechanism or strategy for the germs to fight against microbial resistance. I will talk about how the spreading of antibiotic resistance across system. So if you will see a human will take the antibiotics because he had upper respiratory tract infection. And this is mainly, it's a viral, but you know, the prescriber prescribed for him antimicrobial. So he will take, and again, antibiotics, they will kill the good, you know, bacteria and the bad bacteria, and then he will develop the resistance bacteria in his gut. So he will become sick. We will admit him to the hospital. Okay, and then he will infect those patients in the hospital because he had resistance organism. And it can be disseminated over the service from one patient to another, or he will disseminate the resistance organism to the healthcare provider. They will transmit this resistance organism to another patient by attaching the services. And then even the healthcare provider, he will go to the community and he can transmit this to the community. Or he will not become sick, but he will have resistant organism in his gut, and he will go to the community and he will spread this resistance bacteria to the old people in the community. In the contrast, you know, the animal, they will get some antibiotics, and even they will develop resistance bacteria in their gut, same as a human process, because he will get like a flu-like illness, or maybe the provider, he will provide or prescribe certain antibiotics for the animals, either because it's a part routine for them, or he has some animal sick. So those kinds of antibiotics make a resistance in their gut. And again, either drug resistance bacteria can remain on a meat, and people, they will eat the meat. Maybe they will cook not in a proper way, or they will handle the meat. So it can be transmitted, the resistance bacteria, to the community. And you know, or you know, the fertilizer or water containing animal feces and drug resistant bacteria used in food crops for farm people, so it can be disseminated to the food, and you know, from the food again it will go to the human and to the community. So it's like a cycle from everywhere. So antibiotic, it can be spread once it's reached the community. It can be spread to the other countries because people, it's traveling. So that's why we are seeing, for example, like a lot of MDROs, like NDM, New Delhi, when they started there in India and the country, then it spread to us. Why people, it's moving around, traveling. That's why we are receiving a lot of resistance organism. And that's why certain hospitals outside or abroad, they put certain restriction for us. They cannot receive any patient from us unless they have to do screening that there is no extended spectrum beta-lactamases or certain XDR or MDR. Otherwise, if they found any XDR or MDR, they will not accept any patients to travel abroad. So this is, you know, food, people, animal, environment. It's a One Health challenge for us, and they are connected to each other. And antibiotic resistant germs can quickly spread across the country, communities, the food supply, the healthcare facilities, environment, soil, water, and around the world. Antibiotic resistance is a One Health approach and a One Health problem. It's connected to the health of the animal and environment, like soil and water. It can affect our progress in healthcare facilities, food production, life expectancies. Antibiotic resistance, it's a global crisis, by the way. And new form resistance emerge and can spread with, you know, remarkable speed between countries through, as I told you, people, animal, and food. So we need to have a healthy people, healthy environment, and healthy animals. So I will stop here as a part one.
Right. Thank you very much, Dr. Muna. This is quite informative. So audience, if you have any questions, please type them in the chat and I will pass the questions along. But I have a question for Dr. Muna. Given the impact of COVID-19 on AMR, and the increased burden of antimicrobial resistance. Here in Qatar, did you observe certain pathogens to emerge with higher resistance compared to the usually seen before COVID-19? Is there a new category of nosocomial infections?
Thank you, Dr. Susi. To be honest, the COVID era, we encounter, of course, a drug resistance. And if you know that this is a majority, announced deaths in ICU because of MDROs organisms. So we encounter an outbreak, and this outbreak was due to Candida auris. Especially Candida auris. It started in one hospital, then the patients moved from one hospital to another hospital, and in case of any very serious disease or infection, we are not promoting transfer patients. We prefer the patient to stay in the same hospital. Candida auris was the main challenge for us, and it's not only us; it's worldwide, globally, and other infections like example for us, Pseudomonas aeruginosa, Cynotrophomonas, Acinetobacter. This is all ICU's organism.
All right, thank you. So you just touched on the implementation of measures to prevent AMR spread in Qatar. Can you please expand a little bit on your approach at Hamad General Hospital? How do you limit the spread of AMR in the hospital, and at the level of the country, how do you limit the spread of AMR in the community?
To limit the spread of antimicrobial resistance, you need to have, of course, policies and procedure, and we don't want to forget infection prevention control. So, of course, in healthcare setting, is different than the community setting. Community setting, we are educating people about hand hygiene, about vaccination, about food preparation, about sanitation. But in a healthcare setting, we have a policies, we have a procedure, we have infection control practitioners. They are moving around just to monitor the healthcare provider practices from hand hygiene practice, of course. And even if any patient has like MDROs, or if the healthcare provider apply precautionary measures or no. We are encountered during why the AMR, why the Candida auris and other MDROs was increasing during the COVID-19, especially the ICU. Don't forget the crowdness of patients, shortage of the supply, implementation of infection prevention control was very difficult. So why? Because the capacity in each hospital was increased. Once there is a crowdness, infection transmission will be easy and fast.
Right. Dr. Muna, we have questions from the audience. So they're asking, Lubnazar is asking, do pesticides in plants and crops contribute to AMR?
Wallahi, to be honest, I don't have idea, but I think it's contribute to AMR. So if you will ask me about environmental, culture, food, maybe later on, I don't know, or now I will talk. From national perspective, as you know, WHO, as you said, endorsed a global, antimicrobial surveillance. So to talk to the all countries, they have to report nationally about the DROs, XDR, CLABSI, sepsis, everything nationally should be endorsed to and reported to the WHO in a glass project. But when we started Antimicrobial Stewardship program, before there was no connection between like health and agriculture, or even environmental and food. And we have up to now, I cannot say we are 100%, no, but still, but at least we know what they are doing. So food chain and food supply, they know exactly what they are doing. And they even imagine that they are doing tests for imported food. And they are going to the farm to check with them. and they are putting for them policies and guidance. But I cannot tell you that 100% they are buying in with us. Food, yes, but you know, animals is still because we started, we launched antimicrobial stewardship program maybe as a national one 2018. So imagine that 19, at the end of the 19 COVID, it came, so everything was stopped, to be honest. So, but at least they did partial, you know, meeting with them. In regard to the service, we are doing, and Hamad Medical Corporation, as you know, because you are a clinical microbiologist, you know that Hamad National Hamad Microbiology Lab will be considered as a national AMR lab. We are depending on microbiologists to do for us, like how to do the surveillance for antimicrobial resistance. In the food, they are doing great job, but it's not optimal. But for animals, still, you know, because the animals, there are a lot of veterinary, they are utilizing antimicrobials, and they need to test antimicrobials on animals. Still, because even, you know, I don't know about the animals, they have a lab, so it's different entity. But I agree that all of them, they need to sit in one table and to discuss. But it's so difficult. It's everywhere. It's difficult. It's not only in the state of Qatar. Everywhere they are, you know, feeling the pain, the same pain that we are feeling it in our country.
Yes, we face it all together. I guess a couple of questions also from the audience related to what you just covered about the guidelines and the specific measures taken to limit the spread of infection. If you could quickly, for the time limitation, answer. One student is asking about the black fungus outbreak in India during their mass COVID wave that occurred. I think they're referring about mucor infections.
Yes, so why it's in India, they have like mucormycosis. And by the way, it's even they reported, you know, by CDC, it's an outbreak, aspergillosis, pulmonary aspergillosis. It's not only mucor. There was pulmonary aspergillosis as mucormycosis. Why? Because I don't know about their health system in India, of course, but I think they are utilizing a high dose of corticosteroids. So people, they get infected with the COVID, immune system poor, risk factor, dexamethasone, they are utilizing with a high dose, prolonged hospitalizations, you know, this is all will be end up by fungal infection. It's well known with the poor immunity, with the high dose of the steroid, will get easily mucormycosis. The other, of course, chronic medical condition like diabetes, especially if uncontrolled.
One last question before we move to another section. One attendee is asking, that's Ola Yakti is asking, you mentioned that there's a very small percentage of patients getting pneumonia that requires antibiotics. Did you optimize the use of antibiotics then, or it's being used, if I may continue the question, as prophylaxis actually to prevent secondary infection?
No, we are not encouraging to utilize antimicrobial as a prophylaxis. No, once COVID-19 patients admit to the hospital, I agree with you that in the first day, second day, he's febrile, may less bacterial infection. But once the patient is becoming febrile completely, I will stop antimicrobial therapy because I know COVID-19 pneumonia, but it's not due to bacterial. But even I have to look, if you will tell me not to look to the other measures like procalcitonin, because procalcitonin reflects, it's not viral infection, reflects second bacterial infection. So CRP, other parameters, but even CRP, you know, to reflect on COVID-19 infection to be high, but procalcitonin become high. So it's judged clinically and laboratory and microbiology, and as well as this is subjective to the physician even monitoring. But if you will tell me, yes, of course, patient, ventilator, on a central line, he's not responding, requires high oxygen. course, I will let him to continue on antimicrobial therapy because most likely he will get secondary bacterial infection.
Dr. Mona, can you check your mic, please? Because your voice dropped a little bit in the last. I have a quick question to the audience. Please type your answers. Can you quickly name 2 mechanisms of AMR? Dr. Mona explained to you several mechanisms. Just name 2 mechanisms. And the second question to you as well. Do you think AMR is only in hospital settings, or could it be found in the community? Type your answers, please. Dr. Mona, you could proceed your slides to the second part of the presentation.
Sure. So the sound is clear or still you?
It's better now.
Okay.
I don't see answers in the chat right now. Oh, okay, now I see. Yes, gene transfer, modifying drug target, inactivating enzymatic inactivation. Excellent. Excellent. And in community as well. Excellent. Thank you, audience. Dr. Muna, you may proceed.
Now we'll talk about and core elements. This is IDSA and CHIA, the guidelines for developing an institutional program to enhance antimicrobial stewardship program. And this was in 2007. Then in 2016, they put how we need to implement the antimicrobial stewardship program. So define the ASP as coordinated intervention designed to improve and measure appropriate use of antimicrobial agent by promoting selection of the optimal antimicrobial drug regimen, dosing, duration, and route of administration. So we need to have appropriate initial antibiotic, usually empirically. We need appropriate indication, appropriate route of administration, and right dose and right duration. Why? Because we need to reduce the cost, reduce resistance, and reduce unnecessary antibiotic utilization. So the ASP program has a goal. We need to improve both. We need to optimize selection and then duration. We need to reduce adverse drug events, including secondary bacterial infection like Clostridium difficile infection. We need to reduce morbidity and mortality. We need to limit emergence of antimicrobial resistance. We need to reduce length of the stay. We need to reduce healthcare expenditure. So how best can we achieve, how we can achieve this goal? Of course, by evidence-based, by improved patient safety, by financially supporting, you know, it's ANC, it's a need financial support because it's a big program. Improve community resistance profile. And the problem with the antimicrobial stewardship that when I, as a clinician, when I'm going to talk to anyone, he thought that everyone, they know everything. So I will say, so X, Y, and Z. When I will tell him that it's no need to extend the surgical prophylaxis, he will say, no, we need to, because they thought they need know everything. No. What it should be, which always we need to think, which strategies are most effective and how to assess the effectiveness of that strategy even. To implementation and to have an effective strategy, we have an excellent infection prevention control program, effective clinical antimicrobial stewardship, surveillance on the place, and monitoring of MDROs and XDROs on the system. And when we are talking, it's not talking about the system that's in healthcare, we're talking about national-wise. So there is they put a lot of effort to control the resistance. We need to develop the new drugs and vaccines, and we need to have reduced the resistance reservoir. We need to focus on the research, education, infection prevention, as well as, you know, improved diagnostic. There is a lot of talk about diagnostic stewardship. What's the core elements for antibiotic stewardship program? There is a core element for antibiotic stewardship program, and it was updated in 2019 to reflect both lessons learned from 5 years of experience. A major update for the hospital, you know, core elements include, you know, hospital leadership commitment. It's 7 elements. So we have a hospital core element for hospital antibiotic stewardship, for nursing, and for outpatient. So for hospital and nursing, it's 7 elements. For outpatients, it's 5 elements, 4 elements. So for hospital leadership commitment, we need to dedicate necessarily human, financial, and information technology resources. Why dedicated time and resources? It's important for us. We need someone to operate the program effectively, along with ensuring that the program leadership has regular scheduled appointment. He needs to report to the stewardship initiatives, to the senior leader management and executive. Otherwise, there's no benefit from the program itself. So this is the updated one. So I will go back and forth to compare between them. So they add report regularly and time. For accountability, we need to appoint leader or a co-leader, so such as a physician and pharmacist responsible for program management and outcome. But for the 2019 update, they appoint pharmacists as a co-leadership. Why? Pharmacy expertise, it's very important for us because they will give a value for that program. For the pharmacy expertise, previously they called it expertise. Now pharmacy expertise, they appoint pharmacists ideally as a co-lead for that program, because pharmacists help us implemented effort to improve the antibiotic use. Pharmacists, they are good in policies, procedure, monitoring, de-escalation, escalation, switching IV to oral. There is a lot of intervention they can help physicians to do. Action, implement interventions such as prospective audit and feedback, and or pre-authorization to improve antibiotic utilization. So 2019, they put or add other interventions or priority interventions, and other interventions, they make a categorization, either the intervention infection-based or provider-based or pharmacy-based or microbiology-based and nursing-based intervention. This is like other intervention. They focus on prospective audit and feedback, pre-authorization, and facility-specific treatment recommendation. For tracking, we need to track, of course, we need to monitor antibiotic utilization, prescriber, and what's the impact on the intervention itself. Of course, I give him pre-authorization. That's mean he wrote something restricted antimicrobial. Then he called me, I discussed with him. Then he wrote the antimicrobial we need to monitor this. Even if I give him the approval, we need to monitor that intervention. And we'll see like reflect for MDROs and resistance pattern in the facility. Reporting, it's very important also, regularly reporting information on antibiotic utilization, which type of MDROs. It needs to be reported to all. It's not only to the senior leader management, to the prescriber, to the nurses, to the pharmacist, to the hospital, leadership. So we need to align with the program. Otherwise, I will report to the leader, but the nursing, they don't know what's going on. Prescriber, they don't know what's going on. They will be not buy in with the program. So we need them. We cannot do alone the program. Reporting. So reporting, we need to report regularly. So education. There is a case-based education. They call it Handshake Stewardship. And this is something updated in 2000. And it can be happen through prospective audit and feedback and pre-authorization. So prospective audit and feedback, that's mean I will go to see and audit them based on our clinical guidelines. What's the prescriber he wrote? It's like he deviated from the guidelines or no, appropriate antimicrobial or no, and I need to give him feedback. Okay, this is especially powerful when there is a case-based discussion. At least it's like sort of education and feedback to the prescriber. And also they suggest an patient, we need to engage nurses in a patient education effort, because the nursing, they have also an excellent role. What's the core element for antibiotic stewardship for nursing homes? Nursing home, as I told you, it's antibiotics are among the most frequently prescribed medications in a nursing home. It's reached up to 70% received one or more courses of systematic antimicrobial therapy in a year. The core element for antimicrobial stewardship for nursing home is 7, same as the previous one. I will not go in details, but what I will say during this is while the element, for both for hospital and nursing home, it's the same, the implementation for these elements may vary based on facility setting and resources, and even it's different from one facility to another facility. Nursing home are encouraged to work in a step-wise fashion, implementing 1 or 2 activities. And to start, and gradually we need to build our own KPIs or a new strategy from each element over a time. So any action taken to improve the antibiotic utilization is expected to reduce antimicrobial resistance and prevent emerging of resistance and lead to better outcome, especially for elderly people. For outpatients, antibiotic stewardship, it's 4, it's not 7, it's 4 element, and in the outpatients, clinician and facility leader can commit to improve antibiotic prescribing and take action by implementing at least 1 policy or practices, like I will need to look the upper respiratory tract infection or urinary tract infections, prescriber, and I need to audit them. I need to give them a feedback. So this is all aimed to improve antibiotic prescribing practices. So clinician and leader of outpatients, they can sit together and can track antibiotic prescribing practices and regularly report these data back to the clinician, to the nursing, and can provide education resources to the patients and family on the appropriate antibiotic utilization. So I will talk, this is part 2. So we finished the core element.
All right. Thank you very much, Dr. Muna. So I'm going to ask the audience, if you have a question, please type it right now. And until they do, I will ask you the following. You already spoke about the surveillance program here in Qatar. Can you specifically explain the role of the Clinical Microbiology Lab as the main place where they keep the tab and the monitoring of antibiotic resistance in pathogens?
So as you know, in each country, in each facility, let's to say, because it's like all of us under one corporation, so it's easy for us to have a local, resistance pattern, which is the antibiogram. This is very important for us to combat antimicrobial resistance, and to, especially for physicians, they need to know local resistance pattern, which is the antibiogram. Second, the all AMR data is with the microbiologist, so they have a certain surveillance on the system, plus with the help of infection control, of course, because infection prevention control also, they will monitor and they will do reports, especially for the CORTI, for the CLABSI, for skin and soft tissue infection, with the help of clinical microbiologists. So both of them, they can represent the data. But what it's happened in Qatar, that with the agreement to the Ministry of Public Health, so the clinical microbiology directly will report to the WHO through Ministry of Public Health in regard to the surveillance report from, they need to say how many percentage bi-monthly of MDR for certain, like Clostridium difficile, extended spectrum beta-lactamases, Pseudomonas aeruginosa ban, MDR or XDR or ban resistant, Acinetobacter, so certain microorganism which is categorized based on WHO and CDC series of threat, they need to report it. They need to report, the utilization of antimicrobial. As a clinician, I need to report to the Ministry of Public Health the consumptions, the DDD, It's not important for the national to know who the prescriber, but it's important for the facility to know the prescriber, the name, the location. This is very important for us.
I have a question from the audience here. The first question says, how can protein alteration affect AMR? I think, Mohannad, you mean how can antibiotic target alteration affects AMR? When the bacteria changes its target of this particular antibiotic, the antibiotic gets there but cannot find the binding site or the pocket, and then the bacteria changes its binding target to evade killing by the antibiotic. Do you want to comment on that, Dr. Mona?
Yes, I agree with you. I mean, I agree whatever you said, Doctora. It's a lot of mechanism we have from the resistance pattern, but it's all when we are doing genotype to know the mechanism of resistance in a state of Qatar. I don't think so. We have lots of application in this regard. Maybe this is pure basic science, and it can be done through like Qatar University or Weill Cornell University. But as a clinician, we are not doing those kind of basic science research.
Right. No, it's going actually looking at the molecular determinants of antimicrobial resistance is ongoing at the BRC, Qatar University, and the Basic Research Lab. There's another question related to, okay, as a clinician, you receive the report that this patient has AMR. The antibiogram says it's resistant to the antibiotics. What would you do?
Okay, so when we have, of course, any patients, they will admit to the hospital. First, we will start antimicrobial therapy. To review patient history, we need to talk to the previous data, if he had any culture, if he's well known, because the system, if he is like MDR, it will alert us that he had previously MDR. So once we know that he's previously MDR, we need to act empirically. We need to think based on the previous culture. We will start him broadly on antimicrobial therapy. Then, of course, we will do for him all the septic workup based on his presentation. And we will wait for we get the result, and the patient, he gets like, MDR, we will act. We will change the antibiotic completely based on the culture and sensitivity.
Right.
Our lab, for us, like a breakpoint, which is minimum inhibitory concentration, like MIC. No, it's they will put for us as a resistance, sensitive, or intermediate.
Right.
And we have like some patients, they will get the antimicrobial based on the sensitivity and insensitive, but as a clinician, still I'm worried, and I don't see any like clinical improvement from the patient side. I will go back to talk to the lab. It's right, it's sensitive for my patient, but still he's sick, he's not responding. So please give me the MIC, and based on the MIC, I need to decide. Because it's like we need to decide either we'll give him like prolonged infusion or depend on the concentration of the drug level of antibiotics. So it's a lot of work with the clinical microbiology.
And in these cases, when you have a patient with MDR or organism, do you use the combination of the last resort drugs to save life, or?
It depends on if we have like, of course, it's if I have like MDR or XDR, I utilize combination therapy. And combination therapy based on the organism itself. So if we have like Pseudomonas, MDR, I will utilize beta-lactam plus, aminoglycoside, or maybe third treatment. It depends on the microorganism.
Right.
We are like, especially in XDR and MDR, one resistance for one class. Of course, I will use monotherapy. It's not combination therapy.
Okay, great, thanks. I have a quick question to the audience. Please type your answers. Can you name 2 IPC measures, infection prevention and control measures, that you as a future clinician or already practicing? Name 2. Type your answers, please. All right. And the other question to you and to Dr. Muna as well, we already kind of touched on that, but I want to reiterate the concept. What happens when you use empirical antimicrobial therapy to treat infection, but it is encoding AMR? You will end up having treatment failure. And in this case, what you just mentioned in the previous question, exactly, you have to do combination therapy and do excessive monitoring to your patient to make sure that they get the infection under control. There's a question, how do we limit human-to-human transmission? Yeah, how do we limit that? PPE is a correct answer. The person who wrote limit human-to-human infection, the basic procedure and the effective one is thorough hand washing. It is very important measure in the infection control and prevention. The first step in breaking the chain is hand washing. You will learn more about that in the coming time. But for the sake of time, we're going to ask Dr. Muna to proceed for the last part of her presentation, and then we'll open the questions again, and we have 2 cases to discuss with you. So Dr. Muna, you have like 15 minutes to complete. Go ahead.
So 15 minutes, so that's me. I need to make it short. Okay, so I'm going to talk about current. So at the national level, we started the National Action Plan to combat antimicrobial resistance was in 2018. But I don't know if they will expand or no, because we stopped during the COVID. It's almost 1.5 years or 2 years. So the AMR program governance structure, it's the National AMR Committee, and I'm going to focus, there is a 5 technical working group. I will focus on stewardship program group, and there is a group, another AMR research and innovation, a technical working group in infection prevention control, and a technical working group in integrated AMR surveillance, as well as another group for advocacy, education, awareness, communication, and behavior change. So as a national expert and professional from the relevant sector set together, human, food, and animal, and they did like situational analysis. They looked at the strength, weakness, opportunities, and threat, and they developed the aim and the priority intervention for their respective strategic objective, and present their finding to a bigger audience to provide more feedback. So I will not go this in details in regard to the strength, weakness, and opportunities and threat. And based on the act, so the objectives from the National Action Plan was to enhance the awareness, understanding, and change of behavior antimicrobial use, which is along national health strategy. They developed nationally integrated and coordinated AMR surveillance program, including antimicrobial use monitoring based on One Health approach across the sectors. They developed and promote interlinked informed national infection prevention and control program across sector, including IBC and human and biosecurity and biosafety and animal health and food safety. They optimize the use of medicine in human and animal health, and they promote also AMR research in alignment with the national health strategy. At corporate level, we have, a multiple hospital shared antimicrobial stewardship program. We started our journey in 2002. We have a restriction policy, we have antibiogram, we have specific infection guidelines, and this is all interventions. And this is our own antibiogram. So we started a real ASP program. It was in 2016, and it was manually. We did monitoring of antibiotic and interventions. So we filled, you know, a manually monitoring form for a prescriber, and as you know that we get like a support, and we have a clinical governance in 2018. It's involved 12 hospitals, it's 10 tertiary hospitals, 2 community hospitals, and now, to be honest, 3 community hospitals, and home care, inaya, and mobile services. All of us GCI accredited since 2006, total beds around more than 2,000, ranging between 600 to 65 beds, and governance by corporate ASP committee. So we have national, we have facility. Corporate, we have a leadership support and commitment, and we are doing monthly meeting, and this is before COVID era, of course, and it's led by infectious disease physician, and the members sit in that committee, chairman of antimicrobial stewardship program in each facility, with the executive director nursing and corporate MU, and a corporate representative from IBC. There is a certain responsibility for the corporate AC committee, development and management of the program across HMC, oversees operationally AC's program teams, activities for antimicrobial use monitoring and compliance, production of annual report summarizing even level of antimicrobial use, AMR, and the impact of the stewardship initiatives. They have also a production of annual plan or service plan for antimicrobial stewardship. So we need to submit to the corporate as a facility annual plan, and the corporate, they need to submit to the national annual plan. Collaborate with the corporate pharmacy and therapeutic committee for presenting antimicrobial stewardship annual activities, either to delete, to add, to continue certain antimicrobials, guided by the criteria of formulary update. So ASP initiatives, we have corporate antimicrobial committee. Corporate, that's me because it's a 12, 13 hospitals. Antimicrobial stewardship team round, they are doing round. We have guidelines in the place, we have antibiogram, and we have electronic decision support. Electronic decision support, it's not that much optimal. Still, we are negotiating with the computer, which is clinical electronic decision support, to help us to put alerts for us. So, and a lot of things to guide the prescriber even. So we have a leadership commitment. We have ID lead the antimicrobial stewardship program, and we have a pharmacy co-lead with that. So there is in each facility ID with the pharmacy co-lead. So we did a survey to assess the knowledge and attitude of the physician and related to the antimicrobial stewardship policy, if they know about the antimicrobial policy, if they are seeing ID communicated with them. Any assessment, it will be happen after 48 to 74 hours from infectious disease. They are getting a call from pharmacy every time once they will prescribe restrict antimicrobial therapy. So this is sure just to know their knowledge and attitude toward you know, AMR and antimicrobial stewardship program. But also we did it for pharmacists to know what's the role of the pharmacist and the antimicrobial stewardship. What sort of the intervention they are doing, escalation, de-escalation, switching from IV to oral, just discontinue antimicrobial, and you know, education, follow up for the patients, checking the result. So this is like, it's like give us an idea what's their role and what's their, you know, satisfaction working with the infectious disease colleague. Accountability and pharmacy expertise, I mentioned before, that's we have pharmacy, and we are accountable to do this program. So this is, you know, maybe it's very important to know that as a ASP committee across the system, it's to know everyone role, what they need to do in the sitting in the committee. It's multidisciplinary team approach to optimize, you know, a stewardship program. The core member, it's the ID and the clinical pharmacist, and there is also additional member. It should be clinical microbiologist, information system specialist, infection control professional, hospital epidemiologist, nursing. You know why? Because we need to every single one buy in with the antimicrobial stewardship program. So for us as a clinician, it's very important to have full engagement or engaging them in this program, and because we need their support and effort to improve the antibiotic utilization. As hospitalists or intensivists, they are utilizing a lot of antimicrobial and they are prescribing a lot of antimicrobial, and also at the same time they have experience with the quality improvement work. For pharmacy and therapeutic committee play a big role helping us to develop, implement policies that will be improve antibiotic utilizations. They can be incorporating stewardship into the order set and the clinical pathway. Infection prevention, they can work closely with the hospital epidemiologist and they can assist with the educating staff, analyzing and reporting data on antibiotic resistance, especially with the MBROs, and they report also to the hospital administration and leader by updating the report on a monthly basis. So everyone has his role. The most important also for us is clinical microbiologists, because really they are playing a big role in antimicrobial stewardship program. So we cannot do without them. They are doing for us the antibiogram. It's cumulative antibiotic resistance reporting, or antibiogram. They can guide in a proper use of tests, because even something now we call it diagnostic stewardship. They can improve, like tests by introducing a new test to speed antimicrobial stewardship program decision related to the antibiotic. Now we are waiting, for example, for blood culture after 3 days to know negative, positive, what's the kind of microorganism. But with MALDI-TOF, that means within a few hours we'll know this is gram negative and what type of microorganism with the biofire. So a lot of diagnostic can be improved. So we call it diagnostic stewardship, to improve the antimicrobial utilization. They can introduce rapid diagnostic tests, new antimicrobial stability testing, interpretation, which is antibiotic breakpoint. That's all impact in the stewardship. Nursing, they are very important for us, and the nursing play especially important role. Nursing, they can for example, nurses can inform decision or a prescriber about whether patients need urine culture or not. Promoting discussion about the antibiotic utilizations, treatment, indication, duration, improve even like, we did with the allergy immunology part from antimicrobial stewardship, penicillin allergy. So they can notify the allergy immunology that the patient has a penicillin allergy, or like they wrote, or history of penicillin allergy. So the allergist immunologist, they can assess the patients and they can say with a certain test, this is allergic to penicillin, or he has no allergic to penicillin, because this will be improved antibiotic utilization. So everyone has a big role in the committee. So in ASP structure, we have infectious disease trained, we have ID clinical pharmacist, we have ID attending with the ID fellows, and we have critical access 24 hours during the weekends. Anyone they can access clinical microbiology, ID, and clinical pharmacist. So facility workflow for us. So antimicrobial stewardship physician and pharmacists utilize different methods to identify patients for ASP review. They will do daily round and they will act based on they will do intervention and recommendation, and they will communicate with the prescriber and the clinical pharmacist involved in the patient's care. This is our own flow. There is a facility responsibility for ASP, general assessment, and there is detailed review. We will assess unnecessarily combination. We will discuss antibiotic use in high location, compare antibiotics utilization to the resistance pattern, looking for a specific agent driving overall high use. There are certain things assessment we need to do. A detailed one, we review a specific infection. This is indicated or not indicated. We will review, you know, if like to treat the resistance organism, either gram-positive or negative. Selected courses of broad spectrum therapy, review prolonged courses. So we can pick through clinical pharmacy, and this with the help of pharmacy informatics. They are helping us, to be honest. So there is a lot of stewardship action. There is, as I told you before, it's like prospective audit and feedback, as well as pre-authorization. And this is all to give like education to the prescriber, and we will utilize all our own intervention. So I don't know if you have time, or just I will mention like the intervention.
Yes,
we have.
We'll give you 5 minutes because this is very informative. If you mention the intervention, and then we proceed to question and cases.
Okay, so I will talk about intervention, then I will stop. So so the active intervention before treatment or prescriber, when he will prescribe the antibiotic, which is the pre-authorization order set. Pre-authorizations, as I told you, we have restricted our antimicrobial formulary restriction list. So no one can prescribe anything unless he will communicate with the leader or ID or pharmacist. And this is, they will be case-based discussions, and there will be feedback. And this is active before writing the empirical antimicrobial therapy. And this is active, you know, measures. After a treatment and prescribing for the patients, there will be like prospective audit. We will audit whatever it's prescribed with the intervention, and even we will give a feedback for them. So you started an IV, why there is no switch from IV to oral, why there is no, or you can do a dose optimization and increase the dose because his creatinine clearance for him, it's fine. So this is sort of active measures or intervention. There is a passive interventions, especially unrelated before prescribing for the patients under pre-authorization, which is like audit and report or education or guidelines. This is all, you know, we will educate, we will give pamphlet, brochures, look to the guidelines. This is all like passive. There is no interactive, there is no case-based discussion. This is all passive measures. After treatment, also there will be like de-escalation or duration of the therapy. This is considered a passive, it's not an active measure. So this is all type of intervention. And of course, I will mention the advantage, disadvantage to take like, you know, more than, you know, 5 minutes. So we need, we as our practice in HMC, microbiology, they will generate for us antimicrobial list for all bacterial patients. So we are using a clinical decision support electronic health system. They will generate all bacteremia list for us, and we'll take this bacteremia list and we'll review the patients, and it's like if the antimicrobial therapy it's appropriate or it's not appropriate, what about the right dose, duration for the patients. And we'll use also infection control practitioner to look to the and report to us all MDROs across the system, and even like physician requesting antimicrobial approval. So there is a lot of, and now we add penicillin allergy also with the collaboration with the allergy immunology to look to the all penicillin allergy patients. Also, we are planning to do a collaboration with the surgeon. They are utilizing surgical prophylaxis, especially before procedure, and they are continuing an antibiotic because surgical procedure need only during the induction of the chemotherapy or 1 hour before procedures. But still they are, you know, continuing the antimicrobial therapy. So now we are putting a lot of, you know, on the place. We need to complete the antimicrobial stewardship program. Clinical decision support tool. It's like facing challenges for us because Cerner was not helping us a lot. So we used IT pharmacy to generate daily antimicrobial list for all patients. IT pharmacy, he will generate for us DDD, and also he will generate antimicrobial cost for us, as well as automatic stop order for antimicrobial therapy after, you know, 72 hours from initiation without ID approval. Under discussion, we need to discuss, and already I discussed, like since 10 days with the Cerner, HICT, we need to put alert for broad spectrum therapy greater than 72 hours. We need to put alert for 3 or more antibiotics greater than 72 hours, duplicate beta-lactam therapy, duplicate anaerobic coverage therapy, bug drug mismatch they can do for us. And, you know, I discuss, you know, also antimicrobial stewardship program, phone application, and we need to put a business case for that. Challenges for implementing the program. Before implementation, at the beginning, before 2016, there was no clinical governance, no support from stakeholder. Imagine I was talking to the executive leader about antimicrobial stewardship program. At that time, I remember no one understands what I'm talking about. So no baseline data, no electronic health system, resistance from prescriber, and shortage manpower. At that time, we don't have any ID physician or clinical pharmacist. We have this, it's not, was a few, like 4 or 5 people only. Implementation phase, we face difficulties in following corporate antimicrobial guidelines. Resistance from prescriber, especially with a certain facility switching from IV to oral or de-escalation. Electronic health system, it's not friendly used. Leak of antimicrobial agent from generator list. No ASP round during the weekends. Bix's machine implementation using antibiotics direct from the machine and no need for approval. Even a broad spectrum antimicrobial, and emergency department, they have different encounter. Even we cannot generate the data because they have totally different encounter. This is like, it's too much. So we did in certain one facility, which is like cancer facility, we did a software looking to the all ASP program. It's different than Cerner, but we stopped because the Cerner HICT don't allow us, so we need to be all of us aligned. We look to the DDD, we look to the top 5 antibacterial consumptions quarterly. We look to the top 5 antifungal, consumptions quarterly. We look to the cost, total cost of systemic antimicrobial therapy. We correlate the antibiogram with the utilization of antifungal, isolate, and this is very important, the tracking and reporting antibiotic utilization. We need to have a KPIs, which is measures, measures reflecting the outcome, reflecting the process, reflecting the economy, which is financial aspect or even human. So it's very important. And to be honest, it's not all the facility put like a KPIs, and this was the plan, the next step that we need to do that. And within 2 weeks, I will have a meeting with them to put a standardized KPI across all HMC. We correlate the antibiotic utilization with the outcome measures. So how many vancomycin consumption and how many cases of MRSA. So we need to compare because people are utilizing certain antibiotics, but it's not related to the microbiology result. So I think I need to stop here. So we did a lot of education, like in the community. If you will see, we are celebrating World Antibiotic Awareness Week every year, even with the community and the malls and with the healthcare provider, even with the children. So in each facility, this same week, all of us, we are celebrating. So to have a good patient's outcome and safety, you need to reduce the antimicrobial resistance and MBRO. I think I will stop here. Thank you.
Excellent, outstanding information. Thank you so much, Dr. Muna. For the sake of time, I will ask the audience, if you have a pressing question, please type it, but I have a question for you. Yes. Is there a specific antimicrobial stewardship training for residents and for medical students who are doing rotation at HMC? Is that in place to train them to be aware of antimicrobial stewardship?
Thank you for this. I raised this concern to the medical education. but you know, we have antimicrobial stewardship program across all HMC. When any medical resident, they will come to rotate on, or student in infectious disease, I will let them rotate an antimicrobial stewardship like only 1 week, because they will come like 4 weeks only. But if you will ask me if you have a curriculum, there is Infectious Disease Society of America, they put a curriculum for fellows and for attending. And I was discussed with the head of ID that we need to develop or to do the subspecialty from infectious disease, which is antimicrobial stewardship program for 1 year curriculum. But we don't have a specific curriculum for medical student or resident.
I hope it will be in the making soon, so everyone would benefit in fighting this AMR pandemic, if I may say, that is in the making.
But I think you need to raise it from your side also, Dr. Susu, because I don't know if you have it in your curriculum for the medical student about antimicrobial resistance as a curriculum itself.
It's a big core curriculum element that we focus on, and when we do the teaching, they're gonna hear a lot through the years in phase 2 in medical school. Our students would hear a lot about antimicrobial resistance and antimicrobial stewardship and infection prevention programs. So yes, it's included, but when they study for a grade is different than when they are in practice and they have to make the decision as well. In the last 5 or 10 minutes, I'd like to have 2 cases for discussion with everyone. So Dr. Muna would help us and help the audience in answering. If you please stop sharing so I could share the cases. See stop share and completely stop share from your end. On the top, there is orange.
Yeah, okay, there's orange, yeah.
Yeah, stop share and I'll take it from my side.
Yeah, okay.
Right, perfect. Thank you. Let's see if I'm unable to share from my side. Let me see, should be the host. So, I can't share from my side. Do you have the cases to share with us, Dr. Muna?
You can? And no, I don't.
Yeah, all right. Not sure why I should be the host, but it's not giving me the privilege. The panelist, let me see if I could move it. All right, I changed the presenter, so maybe I should be able to share now. Sure. All right, everyone, let's test your knowledge. I will read the case and we'll ask questions, all right? And we'll get some discussion on it. The first case, it will discuss the treatment failure due to AMR. So a 68-year-old male was diagnosed with COVID-19 and placed in quarantine. He suffered from hypoxia and his condition deteriorated progressively before he was admitted to ICU and placed on a ventilator. 1 week later, he developed high fever and symptoms of secondary bacterial pneumonia. Although he was administered azithromycin and ceftriaxone as empirical treatment, no improvement on his condition was observed. The microbiology investigations revealed that he was infected with multi-drug resistant Pseudomonas aeruginosa. So what is antibiotic treatment failure? I don't know if I could see your chat right now because the chat is not clear to me here, but sorry. Right, I see now. All right, so antibiotic treatment failure is because azithromycin is not working against Pseudomonas as a multi-drug resistant bacteria. So it did not, this is called antibiotic failure. What is empirical treatment? When we say empirical treatment, what do we mean? I could read your chats if you type. Right. Yeah, Dr. Muna, would you like to comment? Empirical treatment.
So in general management, patients with a suspected or proven bacterial infection consist of initiation of empirical therapy. That's mean administration of antimicrobial therapy prior to availability of any microbiological data. Followed by, we need to adjust based on microbiological data. So empirically, that means I will administer, but I don't have any microbiological data.
Thank you.
This is empirically.
Right. So why ventilator use increases the risk of bacterial infection? Everyone, you could type your answers. And by the way, VAP or ventilator-associated pneumonia is one of the common nosocomial infections in hospitals.
Yes.
But why do you think ventilator is a risk factor for bacterial infection? What does the ventilator has? The intubation? The intubation
Yes.
is solid surfaces over there.
Yes.
Where the germs grows and make a biofilm and gives opportunity for the opportunistic pathogens to build biofilm and establish infection. That's technically
Right.
why ventilators expose the patient to more risk. Not just ventilators, by the way. Do you know what's common in hospitals, in hospital-acquired infection? Urinary tract infections because of the catheter. Catheter-associated UTIs are also quite common for the same principle. You have the Foley's catheter, you provide a scaffold for bacterial infections to thrive in there. Okay, we have one more question. What are healthcare-associated infections? Right? Is it common to have healthcare-associated infection? Should it happen? Or it's because of negligence? It is not because of malpractice. It does happen in every hospital and healthcare setting in the world. It just, the bacteria are carried within people, and because of being hospitalized, their immune system may be suppressed. Exposure in the healthcare setting would put them at risk. We don't call it malpractice. It does happen in all hospitals, but that's why we have strict infection and prevention control measures to limit and reduce the burden and the spread of nosocomial infections. Because bear in mind, nosocomial infections, usually those set of pathogens that Dr. Muna informed you about today, they carry the highest burden of antimicrobial resistance as well. Okay, Dr. Muna, do you have anything to add on this case before I move to the second case?
Oh, so he had VAB with the Pseudomonas because he had previous even hospitalization. So he was admitted to the ICU and placed on the ventilator. This is what I understand before.
Yeah.
This is like a risk factor for him. So his age, another risk factor. Aspiration with the ventilator or mechanical ventilation, it happen aspiration easily. So all this is a risk factor for ventilator-associated pneumonia. And don't forget that he's sedated, of course, sedation, muscles relaxant, central lines. This is all prone to the hospital or healthcare-associated infection.
Excellent, thank you. All right, we'll move to the second case. And the second case, we talk about the prolonged use of antimicrobial, meaning the unwanted side effects of these life-saving drugs. So the case talks about a 45-year-old female suffered from dental infection and was prescribed clindamycin for 2 weeks. After 10 days, she presented to the emergency department with signs of critical illness and was admitted to the hospital. She was started on IV antibiotics, metronidazole, and oral vancomycin. Microbiology report showed that she developed Clostridium difficile infection. So the first question for you, why prolonged use of antibiotics increases the risk of C. difficile infection? Type your answers and we'll give the floor also to Dr. Muna to answer. Oh, okay, kills normal flora, good. Where does C. difficile come from? Where does C. difficile live? It's part of our normal flora, exactly. But why when you use antibiotic kill normal flora, why we don't kill C. difficile easily? What's with that bug? It is a spore-forming bacteria, so it has the ability to resist the environmental stresses better than other types of bacteria. It sporulate and form a spore with thick shell that prevent and preserve the spore from antibiotic killing. And then when there is no competition from other gut microbiota, it emerges in huge number and secrete toxin, and the toxin do what? What is pseudomembranous colitis?
Yeah.
Yes, Dr. Muna, would you like to comment on that?
Yeah, pseudomembranous colitis, we call it also antibiotic-associated colitis or Clostridium difficile colitis. It's inflammation happened to the colon, and it's associated with the overgrowth of the bacterium Clostridium difficile. And the overgrowth of that bacteria, it's often related to the recent either hospital stay or antibiotic utilization or treatment. And especially with the elderly people. It's not only with the elderly, we are seeing now even Clostridium difficile in a younger patients and in the community. Why? Because of utilization for antimicrobial therapy.
Thank you. Do you think all antibiotics increase the risk of C. difficile infection, or there is certain sets of antibiotics that increases that risk?
So this is the question for me or for me?
I'm reading the chat from the audience and they say certain antibiotics. Someone wrote such as ampicillin. Ampicillin may not be the one, but Dr. Muna would answer that question more accurately. Go ahead.
Yeah. We cannot say all, we can say almost of antimicrobial or antibiotic can cause pseudomembranous colitis. Some of these antibiotics are more commonly linked to the pseudomembranous colitis than others, which include fluoroquinolones like ciprofloxacin and levofloxacin. We call it collateral damage. So penicillin such as amoxicillin and ampicillin, clindamycin as in our case, cephalosporin like cefixime, which is Sobrex, and this is like frequently associated with even like cephalosporin, the second generation, third generation, fourth generation. Carbapenem also can cause with the Clostridium difficile. So they categorize it as frequently associated, occasionally associated, and rarely associated. So almost all bacteria can lead, but it's not all, almost can lead to the Clostridium difficile infection.
Wonderful. Our last question for today. What are the major side effects of antibiotics? Diarrhea, yes. What else? Keep typing. Most of you are typing diarrhea. Allergy, yes. What else? Dr. Muna?
The main side effect, GI upset, it can be vomiting, diarrhea, nausea, allergy, and don't forget microbial resistance. This is our main topic, and pseudomembranous colitis. It's a collateral damage. So once you will give antibiotics, you will damage something else. And this is very important for us and related to the Antimicrobial Stewardship program.
That's amazing session. Thank you very much, Dr. Muna. We enjoyed your presentation thoroughly, and we appreciate how informative and clinically very relevant session. Right touch rightly on a very important topic of AMR. So thank you very much. We appreciate your time, and thank you, audience, for being with us tonight. I wish you all a pleasant rest of your evening. Assalamu alaikum.
Good night. Thank you. Thank you very much.
Thank you, Dr. Muna. Assalamu alaikum. Bye.